Thank you for joining tonight's OTEP clinical case webinar. This is the final webinar of the year, and we have Professor Paul Haber with us, who is also the OTEP project lead, to talk about takeaways for holidays and all year.
Hi, everyone. And I'd like to begin by acknowledging the traditional custodians of the country on the lands on which we meet and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. And thank everyone for joining us online. And we note that we've got a third of our registrants regionally, more than half metro and 10% interstate. So thank you. And people from a range of backgrounds, a lot of GPs, 100 people registered. I'd just like to remind people about the OTEP program, and we've got the webinars every month. You can get an e-certificate for CPD for those who want that, and you can visit the OTEP website to look at various other education offerings, including our webinars, previous resources, and sign on to the OTEP course if you would like it. Okay, please keep on mute. Let's just keep going. You've all seen this before. So what we're going to talk about tonight is about how to manage your practice if you are a practitioner taking leave or retiring, whether planned or unplanned, retiring from practice, and what to do with patients and clients as they wish to travel for various reasons, including overseas travel. So let's move on to the first case. So you are a GP in regional New South Wales now. You're planning a 4-week holiday overseas for a family reunion and to attend a conference. You prescribe OAT for 8 patients in your area, along with your other patient workload. And if you've only got 8 OTP patients, then it's like 5% of your work. 95% of your work is something else. Most OAT of patients of yours are low risk and they're getting takeaways and happy. However, one has recently returned to illicit oxycodone use after his mother passed away. You've arranged a locum while you're away, but the locum has seldom prescribed OAT and there were no other locums available. So here's our first question. You've done some planning for your leave. Do you need to inform New South Wales Health Pharmaceutical Services Unit, PSU, of your intention to take a period of leave? So it's a yes/no answer, and we've got a poll for you to click on, and so far only one person has been bolshy enough to say no. Everybody else is saying either yes or they're uncertain. So let's see if I can end the poll. I've got to get my... And that's the result of the poll that you can see. So thank you for 15 people for offering an answer. So the question for us to discuss is, what are the key details that you need to arrange before you take a holiday? And obviously we're having this discussion at holiday time of year. I imagine most of the audience is planning a holiday. Does anyone want to make a comment or tell me the answer? Does anyone feel like they can just speak up? Could I ask Sharon, is that unreasonable?
Well, I think, have any of us taken a holiday? What did we do then? That might be another example.
So
I can give you, here, Marnie says you shouldn't take a holiday. Well,
Well,
Marnie, I know you shouldn't, because it ends up a lot of work if you have a holiday. But
it
it's a
can
good
be.
idea to take a holiday. But I guess be organised.
So honestly, that is a kind of attitude of the past. And of course, I'm sure Marnie was just joking, and that's fine. And what about when you get sick? So I'm we're going to come to that in a moment. Let's start with what to do with a planned holiday, no crisis. You booked it 6 months ago. So I think the first thing I do, and what's the next slide show? Okay, can you go back? I think the first thing you do is you you plan your holiday. It's really important to take holidays, but for most of us with fairly complicated lives, it really takes a lot of planning. Um, you may have a partner to take leave, you may have children, you may have pets. My God, by the time you've got the whole thing sorted out, it's exhausting. But if you don't do that, you never get a holiday. So you plan that in terms of your family life, in terms of the trip itself, and then you know what and when you want to do. And this is for a longer holiday. We're not talking about just a weekend away, but this example is a 4-week holiday. So what you're going to do is, for about the month preceding that, whenever you see a patient, you book the next appointment. And that appointment will be while you're on holidays, perhaps, or not. So if it's while you're on holidays, immediately you don't do that. You acknowledge that you're going to be away. You know the holiday's coming up. You look in your diary. No, I can't see you in January because let's just say it's January, I'm away. So let's book you for when I'm back. Point one. Point two, let's check that you've got all the scripts and meds and whatever it is that you need to make sure that you can last until then. And thirdly, particularly at summer holiday time, you ask the patient, are you going away? Because I've booked you for the 2nd of February. Will you be here? And some of our patients are very well organized and structured, and obviously some not. So the first thing is, I think you can get out of half these problems by just thinking ahead, both for you and the patient. So that's step one. Step two is organizing a locum. And now we go to the next slide. So if you are going away, you arrange locum cover with an accredited prescriber. You inform PSU in writing about your absence and the cover arrangement. Now, PSU have a website and an email address. So this does not require, a formal letter on letterhead. You can just send them an email with this information. And it's helpful for them in the event of problems occurring. Make sure that your scripts cover the full time you're away, as I've said, and provide contact details to pharmacy, patient, clinic of your locum so they know what the story is. And of course, make sure your practice secretary knows the details, because that's the person that's going to be left holding the baby when something goes wrong. And for your complex patients, you may need to do more. So you may, in fact, be well aware of a patient like the case study who probably isn't going to be okay for a month while you're away. So you need to think about what arrangements are required. You may need to give a structured handover to your locum. Most of my patients are fine, but Joe Blow, there's a 50-50 that he's not going to be fine. And here's the thing. And last time he asked me for lots of takeaways, and then he started injecting them. So please don't give him lots of takeaways, or whatever advice you're going to make to your colleague. Your colleague is then going to use that advice to set limits on what the patient says, because there's going to be the occasional patient that says, Or Dr. Joe Blow went on holidays and he said I could have 150 takeaways, that sort of thing, which cannot happen. Okay, next slide, please. So now we're talking about same kind of clinical scenario, but the leave is unplanned and you have to take unplanned leave at short notice. And this is exactly what Patrick put in his post. What about if you get sick? And obviously it can happen. It does happen to all of us one time or another. So would there be any additional actions to complete? Next slide, please. Well, that's the answer. Go back. Let's go back and just have a discussion. Does anyone want to make any comments about what to do in the event of this kind of scenario? Dr. Patrick, are you can you go off mute and tell us what you would do or what you would think we should do?
Yeah, okay. I suppose before you even start prescribing OTP, you would have contingencies for when something like that happens. And well, my example is the Northern Territory. There is no GP prescribing in the Northern Territory. I'm down here now in Sydney. So I see how CESLED, for instance, does it and make sure there's cover and everything. And that was the kind of issues we had. So really, if I was to start up, I would already have talked to somebody, maybe in the local accredited treatment center based in the, say, for instance, Royal Darwin Hospital, and see if there is going to be a set of prescribers, all accredited prescribers who could take over in the case of such an emergency.
Yeah. Patrick, I think you've made a few very good points. Firstly, we don't practice in isolation, but in networks. And you either set up a network of support before you see your first patient, or it evolves. You've been there for 6 months, you've been there for 2 years. This is not your first rodeo, not the first time you've taken a holiday. And so you hopefully have had a certain doctor relieve for you for a couple of weeks in the past, and you try and stick to the same game. And obviously you do favors for that doctor from time to time as well. So, that's a network of support. And we have to have networks of support for our lives, not just for our methadone patients. So that's the first thing, I think, and I totally agree. The other thing I'd like to make a comment is that in Australia, mostly we have both community or private practice and public practice or hospital or public sector. And there are places where there is enough in the private and in the public, but there are many other places where there aren't. And if a private GP goes on leave, patients have to be taken up by the hospital or the local community centre or something like that. And in the absence of any other alternative, they accept that that's their role. And so you can use them as the locum. But like anything else, you talk to them about it, you plan it, you give the contact details, you tell them when you're coming back and hand over any challenging patient and inform the PSU. In New South Wales, it's called the PSU, inform them of that plan. Now, so that's getting through the challenges. Now, what if you had to leave at short notice? Look, would there be any additional actions to complete? I think you've just got the same actions, but you've got less time, which means it's going to be more tricky, because instead of planning the patient so that they don't need a script until you get back, you haven't had that ability, and so that there probably will be a problem occurring before you get back to work. So I think apart from asking for some help. And it may be, if you fall over and break your leg, it may be that you have to get your practice manager or secretary or someone to call in to say that you're just not available, rather than and that's the best you can do. Does anyone have any additional comment, or we move on to case 2?
Can I just ask? So at the time, what about at the time of COVID? That was a fairly sudden disruption to a lot of practices. Are there any learnings from that that might be relevant to this sort of disruption, like having an emergency management plan or something, or really leaning heavily on public clinics if available, and maybe public clinics doing a lot more than they would normally have to?
Well, we've had in the public sector, we've had disaster planning, because we've had obviously COVID. We've also had bushfires, we've had floods, particularly in the northern rivers of New South Wales. There was something, one of the methadone units, all their records went down. I think there was a flood in, like a building flooded. So these things have happened, and the larger clinics and the practices can and should develop a disaster plan, because it does there is a certain risk it would happen. And if you've got 5 patients, it's not as bad as if you've got 500, as some of the larger clinics literally have. So the public sector clinics in New South Wales develop disaster plans. So let's go to case 2. So Kylie is 36 years old, a client who commenced on sublingual buprenorphine naloxone 3 months ago at your practice. She's on 16 milligrams daily. She has no takeaways. Her recent urine drug screen has returned positive for benzodiazepines, which you do not prescribe, and buprenorphine. Her partner has planned a holiday for them next month to Bali, in Indonesia, for 10 days. Kylie would like to go on this trip and asks, how can she continue her treatment whilst on holidays? A lot of our patients are going to Bali. They like it more than I do. So should Kylie be recommenced to travel overseas whilst on, should she be recommended, to travel overseas whilst on sublingual buprenorphine naloxone? Yes, no, I don't know. So that's our first question. Give you a moment or two to think about that one. Okay. Okay, let's end the poll there. We're very evenly split. We were almost equal between yes and no, and quite a few unshures. So nearly every country in the world allows patients to travel there and be on opiates. In some cases, they don't have an opiate program, but nearly every country does. And Bali, Indonesia, they do have opiate program, and they do allow people to travel there. How are you going to find out? Have we got the answer on the next slide, Jess?
No, we have another case on the next slide.
We have what?
We have another case.
Okay, so I have to tell you the answer. So when we look for resources on where people are going, the rules are different for a number of countries. They're not all the same. So there's you can just Google it. You can look at the, buprenorphine program Indonesia, or you can look, there's a website called Indro, INDRO, which is, it's actually an old website run by someone in Germany, but they do keep it reasonably current, and it's got the rules for all the different countries. But it's a good website, but I'm not entirely confident that the website is maintained, and rules in different places of the world do change. But you have to figure out whether it's okay. And some of our patients are taking a longer trip and they're going to more than one country. And so you need to understand whether the rules are different in different parts of the world. The next question is, would Kylie's use of benzodiazepines, according to her urine drug screen result, exclude her from traveling overseas? Can we have a show of a poll on this one? Would positive UDS exclude her? Yes, no, maybe.
So I launched this poll along with the first question, and the majority said no, and a couple people said unsure.
Oh, I didn't. Oh, I scroll down. Would it exclude her? So the answer is it would not exclude her. So it's okay for her to travel. So I think it's a clinical judgment. If she's coming in so intoxicated with benzodiazepines, she can hardly walk across the waiting room into your office, then she's probably not fit to travel. But if she's looks clinically well, looks like she cope with traveling very well, she's cooperative, she's cognitively intact, she can follow instructions, then there shouldn't be a problem. Remembering that with the travel, it gets easy until it's really hard and the customs guy says something. So you've got to be able to cooperate with them. So third poll, same patient. So you can open this poll now. What treatment options do you recommend for Kylie so she can travel for her holiday? And you can select more than one. Would you transfer her to methadone, prescribe methadone tablets? Methadone tablets they're tiny little white tablets, so they're very compact, easy to put in your luggage. So in that way, they're a good idea. But would you transfer her to methadone? B, would you keep her on the same treatment, buprenorphine naloxone strips? They come in very thin little strips. They're easily piled up and stored somewhere, so there's no problem with that. Would you transfer her to depot buprenorphine, Sublocade or Buvidal? Then she doesn't have to take any medication with her. Got that advantage. Would you undertake a withdrawal from treatment as she cannot continue her travel whilst overseas? So that one's a bit of a Dorothy Dixer and nobody's selected it. I'm glad to hear that. And something else, we also have no takers for something else. So we're fairly evenly split between remaining on current treatment or transferring it to depot product, and it looks like most people have actually selected both of those options, and I would say that's fine, that they both are decent options. The transferring to methadone is an option usually preferred when we're transferring someone from methadone liquid, which is very hard to travel with overseas, and we would convert them to methadone tablets. So that would be a good option in that situation, not a particularly good option for a buprenorphine patient. It can depend a little bit on how long she's traveling for. If she's traveling for a week or two, why would you change a treatment that someone's been on for quite some time and plans to stay on for a long time further? But if, on the other hand, she's traveling for a month or more, then that might be an option. Now, somebody has made a comment, the humidity in barley may affect the Suboxone, may become a sludge, something to think about. My vitamin tablets burst open in the humidity of barley. Well, I think northern New South Wales has its fair share of humidity. Sydney does too. And the packets are actually sealed. I've never heard of that happening. I don't think it should happen. But it's definitely the more important thing to think about. Yeah, Joel Hillman says not within sealed packaging. Thank you, Joel. Joel's a pharmacist, so that's what I was thinking too. Probably a more practical consideration is security of the medication, because you can't have the patients losing these things. They will not be replaced. So let's move on. So how do we plan to ensure she can travel overseas? So now can you show me the next slide after this? I had something for this. Yeah. So firstly, we want to make sure there's enough medication for the trip and allow a couple of extra doses in the event of flight cancellations or trouble. So you don't want her to have to rush to a kit. People get very anxious about supply of their medication. So you want to allow a little bit of extra doses, but not a month worth, just a couple of days, 2-3 days. And remember that, flights come and go at odd times of the day, and you don't want a patient to be forced to rush to a chemist that might be closed, that's 20 miles from their house and things like that. So you've obviously got to advise the patient very carefully to keep their medications in a safe place that is not going to get lost and forgotten, left on the plane. It's not going to be robbed, and to make it clear that it's not going to be replaced. So they really have to be careful with that. It's very important to keep the medications in the pharmacy packaging, the official label, that they provide very good evidence to any customs official that this is not drug trafficking, but this is actually a supply of the patient's own medications. So it's going to have the pharmacist label, which also includes the name and the contact information of the pharmacy that issued the script. It's got the patient's name, and it's got the details of the medication, and it's got the name of the doctor. So it really helps define that the stuff in the packet is the original prescribed medication. Now, patients are often, when they're packing, they throw out the packet and they put the tablets in their backpack and in there, and you've got to say, don't do that. Make sure you keep the packet, the meds, in the packet that came from the pharmacy, because it's got all that beautiful information that will protect the patient and protect the meds. So next. And you want to give them a letter. Now, it's a travel letter. This is a letter to show a customs officer, in the event of being scrutinized, that the medication is legal and prescribed. It's not a referral letter. You don't have to give them the life story, and you actually don't even have to tell them all the other meds the patient's on and so forth. So it's brief, and it's just got to look official. So it's got to have your letterhead or your practice address, contact information. I address it to whom it may concern, the date of the letter, the patient details, the travel dates, country of travel if there's more than one, and state that you're prescribing opiate treatment. I am the doctor prescribing medication ABC for patient XYZ, daily dose and the number of days supplied. I do not state that this is for treatment of opiate dependence. There's no requirement to say my patient has this condition or that condition. It's just saying that this medication is for this patient and I'm the doctor who prescribed it. And then you sign the letter, and it kind of looks pretty official. And I've never had a customs official ring me up. And in my years of practice, I cannot remember a patient even being asked to show the letter, but I presume it happens from time to time. But patients feel much more confident if they've got it. And once you've got one of these template letters on your computer or somewhere, then updating the relevant details for the next patient takes two minutes. So it doesn't have giving them a letter isn't a big deal. Okay, next. That's case number 2. Any questions or concerns about that one? Nothing's in the chat. You're welcome to post anything if you would like to ask a question. And if not, we'll crack on with the third case. So Jimmy's 48. He's an Aboriginal client from APY lands in remote South Australia, but he's currently in your town. He's on wherever that is. 80 milligrams of methadone. He gets 3 takeaways a week. He's pretty stable. He does smoke cannabis occasionally, no other substance use. He's been going well on treatment for the past year. You get on well with Jimmy yourself. At his appointment, he says he's traveling in a few days for sorry business after the passing of a family member. He will be away for 6 weeks. He realizes now that could be a problem for his treatment, and he realizes he should ask about that, and he says, can he continue this while he's away? Next slide, please. So, should Jimmy be allowed to travel interstate for sorry business whilst on methadone? Yes or no? He's going to a fairly remote place, I should say. So if this was an exam, we would have to delete this question because it was too easy. One person has said no. 2 people have said no. Well, it's a bit of a Dorothy Dixer question. The answer is yes. If you stopped his treatment, he would go into withdrawal. So you should both be allowed and encouraged, and the duty is with us to arrange for his continuing treatment. So the answer is definitely yes. Next slide, please.
Paul, we do have a sorry.
Do you need letters?
Paul, we have a question in the chat asking, do you need letters for interstate flights?
I have been asked for one by a patient once. I don't think you need letters for interstate flights. No.
It wouldn't hurt if you.
Yeah, it wouldn't hurt.
Wouldn't hurt.
Honestly, if you've got it on your computer and a patient asks for it, it's quicker to just bang one out than have a 5-minute discussion about whether you should or shouldn't. But I'm pretty sure I have been asked to do that at some point in the past, but it's not common. I should say that our patients aren't great travelers. They don't, they're by and large not doing a lot of traveling. And we would be encouraging them that they should feel comfortable to do that. So case scenario 3, what options do you recommend for Jimmy? And this is another poll so he can travel. And again, you can select more than one. A, do you prescribe methadone tablets, Viseptone tablets? Do you transfer him to depot buprenorphine, Sublocade or monthly Buvidal? Does he stay on methadone liquid, which is his current treatment? Do you transfer him to sublingual buprenorphine naloxone, which is easier to transport, or do you do something else? So Marguerite Tracy says you find a local dosing point if possible. So something like half the participants so far. I'm going to count to 10, close the poll. 8, 9, 10. Let's close the poll. So 8 out of 20 said switch to methadone tablets, Viseptone. 1 person said transfer to depot. 11, just over half, said stick with the current methadone liquid. 3 said switch to sublingual, and 3 said something else. Now, the 3 people that said something else, can you bang what that was into the chat? Just type a few words as to what something else is, and I'll keep talking while we wait for you to type that in.
I just ask Paul, the other thing is to think about amongst all this is, what if Jimmy's very high risk? How does that change things?
Yes, well, let's look at that. So Josh Garley, local dosing point if possible. So three people have said find a local dosing point. So the first thing is that we've said he's fairly stable. We've said he's traveling for 6 weeks, not just for a few days. But we haven't said where he's going, and that's a problem. If he says I'm going on sorry business to Redfern, New South Wales, which is inner city, loads of dosing points, there's an Aboriginal medical service, there's all sorts of things, then he can have a local dosing point in Redfern, click of a finger. But if he said he's going 100 miles out of Wilcannia, then it is a different story, and he can't easily get dosing from there. He's going to have some takeaways. Different jurisdictions have different rules, according to Joel. There's no way DDU in South Australia will give 6 weeks of takeaways of methadone. And Viseptone, that's right. So giving the guy 6 weeks of his dose of methadone, which I've just forgot what it was, but it was 80, wasn't it? It was a moderate dose. Giving someone 6 weeks of that is not safe. And if he's going remotely, I think we would have to negotiate either weekly pickup at a minimum, weekly or bi-weekly pickup from a local, as close to a local chemist as you can manage. Even if it's remotely and you're thinking you might want to switch him to Viseptone tablets, you'd still want to control the amount he gets. And if there is a local chemist or a chemist that's not too far away, he could either be picking up every day or picking up, twice a week or something like that, even if it does entail a bit of a drive. So I think you want to navigate and negotiate a situation that maintains treatment but does not provide him with hundreds and hundreds of milligrams of Viseptone in an unsupervised, unstructured way. I'm just having a look. What about doing telehealth consultation weekly or fortnight to check on him, says Hader. You absolutely could do that. The challenge is if you've given him a supply of meds for 6 weeks, it's, he's either got access to meds or he doesn't. You could, if you're anxious about him, you could say, I'm giving you a supply, I'm giving you weekly takeaways, a supply 2 weeks. Yes, that's what Hader is saying. And then we'll do a telehealth consult. And if we're okay, I will fax a script for the next 2 weeks to the pharmacy. And if that's okay, another 2 weeks, we'll have a quick phone call and then a third fortnight script. You could do that. It depends on your judgment, your risk assessment of the patient, your risk tolerance as a prescriber, and where he's going. But I think the bottom line is that we want to contain the amount of medication he gets while we maintain treatment and demonstrate that we support him continuing his treatment. And we definitely have patients who drop out of treatment while they're doing this kind of sorry business. Now, Sharon has posed a question I didn't answer. What if he's really unstable, still injecting, I don't know what, unstable? Then I think it gets harder. He's going on sorry business in a couple of days. It's very soon, but it's not impossible to transfer him. Particularly, he could delay his travel potentially by a day or two to facilitate that sort of transfer. More often than not, he's not going to want to do that. I think patient wants a certain treatment, and the fact that they're traveling doesn't mean that they want a different treatment. You want them to be on a different treatment, but the odds are that they don't. But it is worth a bit of a discussion because it could make things easier and safer. But Hussam has put in the chat, it would be a turbulent period for mental and emotional health, possibly. If he's gone there for sorry business, someone's died. So it is potentially challenging. So I think that's part of your risk assessment, is considering his mental state and what you think of it. You may that may be a very genuine risk. And so the more high risk you think he is, the less medication you give him. And quite possibly, if he's not too remote, there will be a dosing point and he can be daily dosed with no takeaways. And we have done that in the past, without doubt. And patients can destabilize. And the other thing is they can get up to mischief. They can be with company and they're drinking alcohol or they're using other drugs. So it's not even assessing the patient as they are now, but consideration of what's likely to happen while they're away. And Marguerite says it may take more than 4 days to organise a transfer, and it might. And we have had patients who insist on leaving and we arrange. How do you locate a rural regional pharmacy? There has always been a methadone advisory line that the ministry runs, which is the same phone number as the ADDIS helpline. It's just got a different phone number, comes through a different way. And that Max line can provide you a list of chemists if you know what the local town is. There may be no chemist, and sometimes it is in a very regional, remote type of place. It may be the local hospital. There may not be a hospital. It may be kind of a health clinic, and it may be something like that. And Marguerite suggests you can ask the local health district. If you're in private practice, but you can still ask the local health district in Murrumbidgee, for example. But honestly, getting onto Marguerite's experience of ringing regional local health district opiate treatment units is obviously better than mine. It may be harder to get onto them. I've found that the Max line does actually answer the phone. So one way or t'other, you try and find a local dosing point. Let's get on to the last case, which is number 4. You are now a GP in regional New South Wales. You're looking to retire in the next 6 months. You currently prescribe opiate treatment for 40 patients. They're on a range of pharmacotherapies. The GP taking over your practice is not accredited, has no experience. They are not sure if they plan to become accredited. Again, fairly common scenario. So, point 1, do you need to inform PSU of your upcoming plans for retirement? Poll is open. Yes, no, maybe.
and the second question is also live.
Okay. Do you need to inform and discuss with your local public drug and alcohol services of your upcoming plans for retirement? And I'm delighted that the great majority of people said yes. And over the years, I've had a number of these events, retirement events, and occasionally we hear from the doctor, him or herself. Usually we're hearing from PSU, and usually they're frankly in a bit of a flap because the doctor has 250 patients, not 40, and both the patients and the local service is quite stressed about what's going to become of everybody involved. So yes, you need to inform them. What else have we got there? Is there another slide or is that it?
There were the two questions.
That's it.
Yes.
Yeah, right. So what's the local public health? As you have 40 patients, so there's another question. The GP, if the GP taking over does agree to take the patients, does that GP have to become accredited? The answer is no. Doctors who are not accredited can still prescribe for patients. Can they prescribe for all your 40 patients? So the poll is open on that one now. Can a doctor come in, take all the patients? And we've got a little bit of unsure, but the great majority are saying no. Sorry, I'm just okay. So can we go to the next slide now, please? So what key details need to be arranged and discussed prior to commencement? So you've got, if in the case of this scenario, there's an incoming doctor, you're going to try and encourage them to get into the opiate treatment. You tell them that these patients are quite nice patients. You enjoy working with them. You build them. It helps you in living, and it's an important service, and there's nowhere else for them to go. And if you want to do the course, it's interesting, but you don't have to. However, if you are not accredited, you're limited to 30 patients, I think it is. You cannot commence patients on methadone without being accredited. But you can continue methadone, you can continue, and you can commence buprenorphine. So you don't have to do the accreditation, but once your numbers of patients go up and once you're doing this for a while, you will feel more comfortable to do a bit of upskilling because be more confident that you're treating the patients safely, not getting into trouble. But it's not essential at the beginning. You're going to tell PSU of your plans. Our experience is that by and large, most of the patients when a doctor retires have been on the program with that doctor for a long time. And even if the doctor is in a certain suburb, the patients have over time moved around. And so the impact is not as concentrated locally as you might imagine. And so 40, 80, 100 patients are not going to descend on the practice all at once. They're actually going to be more distributed than you believe. And this seems to be a recurring pattern. So, we don't panic. We make arrangements. A number can stay in the practice. Some may have to be referred elsewhere. Some may have to go to the public clinic or elsewhere. So Does anyone have any questions or comments about that? I don't see anything in the chat, so we can move on to our final thoughts. And so the PSU services offers help and advice. They've got a web page. They've got an online help for SafeScript New South Wales and an online inquiry form. You can ring PSU as well, but it sometimes takes a while for them to pick up the phone. So these other ways of contacting them are easier. Next. So when to notify the PSU, just a summary. Notifications can be made in SafeScript, including permanent changes to a dosing point, managing locum arrangements, and OTP exit can all be done with SafeScript, which once you've got the hang of SafeScript, that becomes easy and fast. New South Wales OTP prescribers are required to notify New South Wales Health in writing of any overseas travel arrangements for an OTP patient. So that's a rule. New South Wales health approvals are available on the PSU website. SafeScript New South Wales should be used to apply for approval, including applying and exiting OTP approvals. And application forms for S8 medications can also be accessed on their on the PSU website. And when applying to prescribe or supply OTP, you have to verify the ID. You seek approval, and it may not be required in certain instances, particularly up to 2 weeks in hospital. But even in hospital, if they're there for more than 2 weeks, we are required to register the patient on the program. Now, I'd like to thank you for joining in. I'd like to conclude, but I would also like to say that the regulations for OTP prescribing are in the process of change. So I doubt that anything we've talked about tonight is going to change, and it's certainly not changing in the next few months. So everything I've said is current as of today and will cover you for the next few months without doubt. But the regulations are under review, and we've been told to expect changes in the middle of next year. So we will be holding a separate webinar to help navigate those changes. I'm about to close, but someone's asked a question, and I think it's a good one, so I might.
There's a couple of good ones, just the last couple.
Yeah, so I thought we might just look at those questions. There's some interstate contacts if you're transferring a patient to another state for a longer period of time, as listed there. And if an unaccredited prescriber does take over prescribing methadone, are they allowed to increase the dose? Yes, they are. They're allowed to change the dose of methadone. They're not allowed to commence methadone without being accredited. So the answer to your question is yes. And Joel says, to you, his knowledge, you must get authority first, but then may continue at discretionary dosing within. Yes. So the thing is that with methadone treatment, you've got a patient, a doctor, and a pharmacist, or hospital clinic. All three must be credentialed or should be credentialed in general. So the pharmacist has to be credentialed, and as you know, some pharmacies do this program and a number do not. The patient has to have specific approval, and the doctor has to be accredited. All three, and it's so it is a highly regulated system. So if the doctor is not credentialed, that is okay up to the limits we've discussed. But the patient still has to be accredited, has to be registered on the program, and they still have to get it from an accredited dosing point. The other two parts still apply. So as Joel said, I agree with Joel, you have to get the authority for the patient, and then and then they may continue at discretionary dosing within the guidelines. And the guidelines are a publicly listed document on the New South Wales Health website. It's much easier to just Google them. Go New South Wales OTP guidelines, and it comes up instantly. Don't sort of try and navigate through the multiple links within the New South Wales Health website. Just Google search for what you're looking for. And let's close by noting SafeScript New South Wales has a useful support service. Public sector AOD services really do want to help in their communities, and the nursing staff, particularly there, have usually been doing this work for years. They know the ins and outs of it all. They often know the patients in question. They'll often be saying, "Oh, yes, we haven't seen him for a while," but they really do know what's going on. And there is a 24/7, excuse me, Drug and Alcohol Specialist Advisory Service, DASAS, that is available for New South Wales. The phone numbers are linked there, and they can provide individual advice to a doctor about a patient, and that is available 24/7. They don't love it when you call them at 3 a.m., but they are available as required to help with any drug and alcohol problem. They help with this kind of stuff, give advice, but they also help with alcohol and any drug and alcohol problem.
Paul, just the two final questions there from Adam and Husam.
Okay. Now, Hussein has just said the service. Whoa. So Husam has just made a comment that I'll read out because it's useful. The DASAS also speaks to pharmacists, and they've been a lifesaver for Husam in the past. So that's worth noting. Thank you. I'm not sure I realized that. Actually, I do realize that. It's interesting. The word Drug and Alcohol Specialist Advisory Service kind of implies it's the service that is specialist. The person asking advice is not a specialist. And that I've had inquiries from nurses, from pharmacists, from other doctors over the years. And so the person who's asking for the advice does not have to be a specialist. For overseas trip, how many days is the maximum we can prescribe? Each country has its own rules, but in New South Wales, I've prescribed for a month, up to a month, a few times. I haven't prescribed for more than a month. I think if someone's overseas in a country for more than a month, they can find their own way. If they are planning a really long trip, then we look at planning a referral to an overseas doctor. I've had a couple of patients go to England for a long time, and we work out where they're going. We work out a local prescriber, and we ring or email the local service, and we link them into that service for the period of time. I've had a patient from England who comes here to see me. He comes for a couple of months. He's come once a year for about 3 or 4 years. And so by now he knows me. He comes to see me. I do his scripts, and he goes, well, then I just arrange for enough scripts for him to get home and have 1 or 2 days. And then he goes back to his normal doctor, and we usually exchange letters to cover what's going on. I don't change his dose. So it cuts both ways. We have overseas patients coming here. So UAE will not permit any opiates. So that's the sort of thing you have to look at that. And Patrick has lived and worked there and says that Joel is correct. Yeah, so I already identified that there's some places in the world that don't permit this, and a patient has to understand that. And if they are firmly committed to going to that country, then and you can't get treatment, then you have to plan a withdrawal so that they don't just go cold turkey.
Paul, did you answer the Hussein's one about Christmas?
No, that forgive me, there are it just keeps growing. Regarding the number of takeaways to hand out, say it is Christmas, Thursday, Friday, pharmacy's closed, patient allowed 6 takeaways, methadone, public holidays. Would the pharmacist be okay to hand out more than 6 to cover them? So, yes, that is outside the usual guidelines, but as a one-off for Christmas in a patient you assess as being stable, yes, it's okay to hand out a higher number of takeaways on a stable patient where you've done a clinical risk assessment and you say this patient is okay. You must make it crystal clear, and I would write in my notes, patient informed no lost takeaways will be replaced, because that does happen, and the patients have to know they are utterly responsible for their own medications.
But I guess as Joel points out, it's got to be written on the script.
Without prescriber authorization. Oh, absolutely. The pharmacist isn't able to issue extra takeaways without a prescription. So the pharmacist, as Joel said, has to say to the patient, yes, I hear what you want. You have to go back to your doctor to get a script for that. And the doctor is supposed not just to say, oh, he's going away, I'll write 6 takeaways, no worries, do that over the phone. The doctor should know the patient and should say, look, he's been stable for 3 years, yes, that'll be fine. Or say, well, he's a little bit up and down, I should assess him. Or perhaps the doctor will say, no, this patient has been injecting takeaways recently, he's been in hospital for something or other, he is not stable. I cannot give him 6 takeaways. I'm not going to do it. Go find another doctor. No.
Or in doses at a public clinic.
Well, that's right. No takeaways. We find a dosing point. And that's hard, obviously, because it's Christmas. Private chemists are closed, and it may be that some of the public sector services are full up and don't want to. So I remember there was a time when the Byron Bay clinic declined holiday transfers because they had hundreds. Everyone's going to Byron Bay at that time. It may still be the case. I'm not sure. But it's not totally taken for granted that patients will be able to access takeaways easily. And so there does have to be some planning and some time allocated to planning this so that it's navigated safely. And whilst holidays are a time of relaxation and joy, they are also a time of family stress, instability, and things going wrong. Mostly they go right. On that cheery note, I'm going to close the session. I'm going to say thank you very much. A lot of good questions, and thank you particularly. Joel made a few comments. So thank you, Joel, Hussan, Patrick. They're the main ones. But thank you everyone for dialing in and sticking it through to the end. Cheers.